Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. Nik Nikam. I have been a cardiologist at the Texas Medical Center in Houston, Texas for more than 3 decades. Today we're going to learn something about second heart sound and its variations. So let us begin. During the cardiac cycle, ventricular pressure exceeds the atrial pressure. The mitral and the tricuspid valves close, generating the first heart sound. First, we have the mitral component, followed by the tricuspid valve component. As the ventricular pressures rise, the aortic and the pulmonic valves open. The soft opening of these semilunar valves does not produce any appreciable sound. However, at the end of the ejection phase, when the ventricles begin to relax, the closure of the aortic and the pulmonic valves produce the second heart sound. Generally, the aortic component of the second heart sound comes earlier than the pulmonic component. However, there are some minor variations in the appearance of the second heart sound during expiration and inspiration. During expiration, the pulmonic component of the second heart sound comes closer to the aortic component of the second heart sound. However, during inspiration, the pulmonic second sound moves away from the aortic component of the second sound, and this is thought to be primarily due to the increase in capacitance in the pulmonary vascular bed, even though in the past it was thought to be due to increased venous return. So you may get a question as to what causes the splitting of the second heart sound during inspiration, and they can give you a convoluted answer. So you need to be prepared for that. Now we are going to look at some of the conditions where there is abnormal splitting of the second heart sound, especially when the pulmonic component of the second heart sound comes much later. Any condition that delays the ventricular action, the mechanical function of the right ventricle, will produce a delayed pulmonic component of the second heart sound. Some of the conditions that can cause a delayed pulmonic component of the second heart sound include pulmonary hypertension, right heart failure, pulmonic stenosis, delayed electrical activation of the right ventricle, complete right bundle branch block, left ventricular premature ventricular complexes, prolonged right ventricular mechanical systole, active massive pulmonary embolus, and decreased impedance of the pulmonary vascular bed, which we see in patients with the pulmonary hypertension, and idiopathic dilatation of the pulmonary artery resulting from pulmonic stenosis. In these circumstances, the P2 comes much later than the aortic component of the second heart sound. And in conditions such as atrial septal defect, we get what is called the fixed splitting of the second heart sound. So, whenever you hear the term fixed splitting of the second heart sound, it should immediately trigger in your mind atrial septal defect. We can also see wide splitting of the second heart sound when the pulmonic component comes much later than the aortic component in conditions such as right bundle branch block, pre-excitation of the left ventricle, pulmonary hypertension, and some of the other causes which increase the mechanical activity of the right heart. Now let's look at some of the variations in the appearance of the aortic and the pulmonic component of the second heart sound. In normal situation, we talked about during inspiration there is splitting of the second heart sound compared to during expiration. We already covered that part. The next is the wide physiological splitting, which we talked about in patients with right bundle branch block or a WPW, where the splitting of the second heart sound is much wider compared to a normal physiological splitting. Sometimes we can get what is called the reverse splitting of the second heart sound. At the beginning, I said the aortic component comes first, followed by the pulmonic component. However, in certain situations where there is delayed mechanical activation of the left ventricle, there is delayed reverse splitting happens when there is delayed activation of the left ventricle or delayed emptying of the left ventricle into the aorta. In those situations, we see the pulmonic component coming before the aortic component, and this variation could be more prominent during expiration. And there are situations where we have a narrow physiological splitting of the second heart sound, where we normally have some splitting of the heart sounds during expiration. However, during inspiration, you don't see much variation in the splitting of the second heart sound. Now, let's talk about some of the conditions that can cause early closure of the aortic valve. Whenever there is early closure of the aortic valve, the aortic component comes much earlier than the pulmonic component. We can see this in situations where there is shortened left ventricular mechanical systole, which can result from severe mitral regurgitation. As the ventricle empties into a low pressure left atrium, there is not much blood left. As a result, the aortic valve closes much earlier. Similarly, in patients with a ventricular septal defect, when majority of the blood is going through the ventricular septal defect from the left ventricle into the right ventricle, there is less amount of blood going into the aorta. As a result, the aortic valve closes much earlier, creating an early closure of the aortic valve. Now, let's talk about delayed closure of the aortic valve or reverse splitting. As you can see here, in patients with the left bundle branch block, pre-excitation coming from the right side of the heart, aortic stenosis, left ventricular outflow tract obstruction. In all these situations, there is delayed electrical or mechanical activation of the left ventricle. That means the left ventricle takes much longer time to empty into the aorta before the aortic valve closes. As a result, the aortic second sound comes after the pulmonic second sound. So, this is called the reverse splitting. That is, normally we have the aortic component coming first, followed by the pulmonic component. But in this situation where there is delayed activation of the ventricle, delayed emptying of the left ventricle, or prolonged left ventricular systole, that leads to delayed closure of the aortic valve, creating a reverse splitting. The conditions that cause this include aortic stenosis, left bundle branch block, right ventricular PVCs, and as I mentioned, delayed activation of the ventricle, prolonged ventricular mechanical systole, or left ventricular outflow tract obstruction, hypertension, and even in patients with angina pectoris, because of ischemia, where there is delayed mechanical activation of the ventricle, that leads to reverse splitting of the second heart sound. What are the conditions where we can see early pulmonic closure? From our first slide, we know that the aortic component comes first, followed by the pulmonic component. Under what conditions can we get the pulmonic component of the second heart sound coming before the aortic second sound? Anything that causes early activation of the right ventricle, anything that results in early emptying of the right ventricle into the pulmonary circuit results in early appearance of the P2. And we see that in early activation of the right ventricle, and in patients with Wolff Parkinson-White syndrome type B. Finally, let's talk about single second sound. The single second sound can result from either both sounds appearing almost simultaneously, or it can appear from either the absence of pulmonic sound or the aortic sound. So let's look at all these three different situations. Under what circumstances can the pulmonic second sound be absent or very soft? In older individuals with emphysema, it may be hard to hear the pulmonic component of the second heart sound, and it may sound like we are hearing a single sound. Similarly, in patients with severe pulmonic stenosis or pulmonary atresia, where there is very little movement of the semilunar valves, that can lead to softening of the pulmonic second sound or almost absent second pulmonic component. Similarly, transposition of the great arteries also produces a single sound because the pulmonic second sound becomes inaudible because of the rotation of the heart and the position of the vessels make it difficult for us to hear the pulmonic component of the second heart sound. Okay, let's talk about absent or soft aortic component of the second heart sound. The one situation where we can expect the aortic second sound to be too soft or almost absent is when we are dealing with a patient with calcific aortic stenosis, when there is very little mobility of the aortic semilunar valves, then the aortic component of the second heart sound becomes very muffled or is almost absent. And this is an important thing that you really need to memorize. You are going to hear a single second heart sound in patients with Eisenmenger syndrome because the incisura of both the right side of the heart and the left side of the heart occur almost simultaneously. So, ladies and gentlemen, this is a brief overview of the second heart sound, the components of the second heart sound, and the variations that you can expect in various pathological conditions. I am Dr. Nik Nikam, and thank you so much for watching, and please do subscribe to our YouTube channel. And if you would like to see a presentation on any other topic in cardiology, please leave us some comments below, and we will see you next time. Thank you so much.